the moderation in the background. And I've got, I'm the person who knows nothing about this topic, and I have 4 people who know an awful lot about it. So let me quickly introduce them. Some of them you've just seen speak. I just saw Abigail Watson give a really interesting talk. Abigail is the founder of Symptomatic IO. She provides a bunch of custom app development for companies, usually on top of Epic, Cerner and others. 20 years of working in the healthcare IT industry. John Loonsk. John is the Consulting Chief Medical Informatics Officer for the Association of Public Health Laboratories, also an associate professor at Johns Hopkins in the School of Public Health there. Keith Boone, many of you just saw him. He's now currently the technical lead for the SANA project. I mean, Keith was working as a technical lead at GE when I met him years ago, more commonly known as the motorcycle guy, because that's what he tends to wear at his conferences. And then finally, Grahame Grieve, who I'm not going to introduce because you all know who he is, with the exception of saying that Jess Massa, my co-host of the Health in 2.0 show, calls him Australia's national treasure. So with that, all right. So that I'm going to kick off with a question, a statement that Ren proposed that we use, and I think we'll enjoy this. I'm just going to throw this as a bit of red meat to the crowd here. He suggested that we should think about this as in 2 parts. So first, in 5 years' time, FHIR APIs are going to be ubiquitous in healthcare. And therefore, in 5 years' time, monitoring and fighting a pandemic won't be so much of a challenge. Anybody want to weigh in?
Well, I'll weigh in on that one right off the get-go. If somebody had said in 5 years, FHIR is going to be ubiquitous in EHRs and electronic health records in healthcare, I would have agreed with that statement. But if you look inside the typical hospital, there's probably 20 different health IT systems that are being used inside that hospital, and only one of them is the EHR system. And only one of them is getting the API love right now, because only one of them has, in my country, any sort of incentive to do that. And yet the data that we need to address the emergency is showing up in bed management systems, in command and control systems used at organizations where John works, like at Johns Hopkins, in ICU central monitoring solutions, in laboratory information systems, et cetera. And while we are starting to see adoption of FHIR in those systems, they are at the stages now where EHRs were 5 years ago.
So that's kind of a yes, but. And Keith, you just mentioned, I just caught at the end of your talk, you were talking a bit about, I guess it's an experimental pilot of integrating data from monitoring devices into the EHR and some other pieces like that. Do you want to say a word about how close that is? Because you assume that, and especially with the talk I just gave, which of course is sort of airy-fairy science fiction compared to the work you guys are all doing, the one I gave earlier today, is about, can we do that in the home? Can we do that for the cloud? Can we do this sort of outside of the current hospital installed base? Where do you think we are with that?
Well, we demonstrated at Connectathon 24 the ability of a system to send a CSV file and convert that CSV file to a FHIR measure report to support measure reporting. And that was very useful. Actually, 3 different systems demonstrated the same capability. It was pretty obvious that this was something that was going to be needed today to support those systems today that have databases that have been around for 10, 15, 20, perhaps even 30 years, and haven't gotten a whole lot of love, mostly because they're doing what they need to do, and there hasn't been a whole lot else that people really thought to do with them, right? People aren't changing labs and laboratory information systems because for the most part, they're doing what people have expected of them. And now we're coming to expect more as we realize, hey, when the stuff starts hitting the fan, we need to dig deeper. We need to see more of what's going on inside the hospital that doesn't usually get exposed. And so we've seen that demonstrated. we've seen that it's a fairly obvious and easy thing to do. And so even though FHIR APIs make things easy, we have to realize that we have, 30 years of brown fields where we have to step carefully and make it easy for people to get from one side to the other. And I see Abby nodding her head up and down. I'm sure you have more to say on this, Abigail.
Abby.
I get the baton. So on the one hand, there's a part of me that feels that if there is a server for an institution that's providing the facade, it kind of doesn't matter if the laboratory system and others are talking to that API server with V2 or database drivers. I feel like there's a certain aspect where what Keith says is absolutely true, but from a black box perspective, like when you're an external person, it might not, or system, it might not, like some of the same functionality may happen. But to the point of, let's assume that even if it is ubiquitous, I still don't think that it's going to solve the pandemic problem. We have a problem not just of being a pandemic and coordinating public health, but it's also a novel virus. It's something new. And so even if we had like 100% ubiquitous FHIR installation, we'd still have to do the genomics. We'd still have to do the research. We'd still have to do all the other things associated with a pandemic. And so I worry about that, and I also worry about whether we over-optimize into just the respiratory virus, and whether we could put this all in place to stop respiratory virus, but then we get flat-footed on a hemorrhagic fever or a prion disease or an antibiotic-resistant bacteria or an STD. Like, these are also types of pandemics. So yeah, I kind of agree that even if we install the FHIR APIs everywhere, it's still going to be its own problem.
I mean, ask you raised a really interesting point there, Abby, which is that if you think about a pandemic, you think about COVID, or you think about any of those other things you mentioned, the place where we are tracking and managing patients is many different places, right? And even worse, as we're just discovering yet again, as we start to open up maybe too early or what have you in some of these states which haven't had such big problems before in the US, and it's been seen in other countries, we need to do a much better job at things that I don't think, and maybe Grahame or John can jump in here, that we thought about in the context of FHIR, which is things like contact tracing, things like understanding where people have been, understanding what level of condition somebody had at what time, and then understanding things like getting testing involved. And we've heard a lot about, obviously, testing, but also seropositive testing. And these are words that, for a guy who failed high school biology, I'm not sure I even know what I'm talking about here. But, the idea about can we establish immunity, there's a whole bunch of records and data here, which is far away from, I think, what tends to happen typically in the FHIR community has been aimed at within some typical hospital and clinic world. So if you, Abby or John or Grahame, want to comment on that?
Go ahead, Grahame.
Okay. The thing that I've learned from watching the pandemic response around the world is the first thing that happens is everybody goes with the battle plan that they have. And there's an old aphorism about a war, which is you're always ready to fight the last war. And so you see people executing on plans, for instance, using temperature surveillance, body temperature surveillance. It's clear that's a waste of time, but they're doing it because they were ready to do it, and so they're going to do it. So you go with the plan that you have. And the other thing that I've learned really clearly is your first response is critical. So looking around the world, people are like over all the response protection mechanisms and giving up. Either they've worked or they haven't, and that's with the dice is cast, and we're moving on. And so first response really is critical. Abby's right that we have to worry about more than just respiratory viruses, but we certainly have to worry about respiratory viruses. We've pretty much had a pandemic starter every few years. It was, it seems reasonable that we'll keep having them. And the other thing that we should learn from this, or we will learn, is that public health saves lives and public health protects economies. I think that's going to be a really key lesson. If you want an economy, you want to have good public health. It's not enough to say that public health is some kind of abstract, do-gooder concern. You want money, you need an economy. You want economy, you need health. And so the other thing that I'm seeing when I talk to healthcare systems is a new awareness that they were caught flat-footed. They had systems, but the sudden sweeping change that ripped through the healthcare system with telehealth, with sudden reprioritization, with sudden relocation of staff, with sudden dependence on virtualism, has really yanked people out of the CIO types, out of their complacency, saying, we have a plan, we're executing the plan, we're doing okay. Suddenly they're like, no, we were not, we were in a rut, and we really need resilience. And so resilience equals APIs. So the question is 5 years time. So 5 years is about, if you were doing a dev now, you would be delivering in 5 years time. It's pretty, standard life cycle. The bigger the system, maybe it's a touch slower, but the kind of systems Keith talked about, yeah, that's kind of 5 years. So are they going to respond now by creating APIs? And I think any IT person will look at it and go, we need APIs. One thing that I'm seeing, particularly with my local hospitals, is they're coming out of this process going, our investment in collaboration software saved us. Whether it's Teams or Zoom or Slack or integration platforms between those, we suddenly depended on them, and we found that people actually like those. They work well. And in fact, they're more efficient than some of the old ways we worked. But now we've created parallel universes between our collaboration software and our EHR. And I'm hearing a lot of noise about integration between the two. How do we make the EHR seamlessly part of the way we're actually working? Suddenly we're working differently. And that's going to mean APIs, right? APIs is a constant theme, which happens to mean FHIR too, but API is much more important. So we will have them. We'll have them maybe in the 5 to 7 year time frame, and they'll make responding less of a challenge, but only less, because pandemics remain a principal issue for us to face. So that's kind of how I see it.
So I would like to chime in on the fact that I think that there is always going to be that variability in not just pandemic, but public health emergency events. I was involved in the anthrax attacks when those occurred back in the US, West Nile, SARS, monkeypox, Katrina, other responses, and they were very different, but they also had a core infrastructure that was needed. I think FHIR API will help with that core infrastructure, but we need to also keep our eye on the fact that that core infrastructure includes EHRs. It also includes public health surveillance systems and other systems outside of the clinical endeavor that are necessary to a public health response. For me, what we've done with the FHIR API in this outbreak, in COVID-19, is to develop an app that will allow for electronic case reporting, even though that didn't exist before. And that's a great FHIR accomplishment, to be able to convey that kind of capability in this kind of time frame to EHRs that didn't have it. That's significant. But that all being said, there's an adage in public health that is, the good systems are dual use systems. They're systems that are implemented in routine times. They're systems that are used on a regular basis by public health professionals and others. And then they can expand to accommodate the complexities and the scale of an emergency event. Because that's the only way you're going to do it. Even if you can convey the technology, that doesn't mean people are going to be able to immediately pick it up and use it. So I'm going to be talking on tomorrow at 3 about the UCR Now FHIR app, which is, I think, a testament to the FHIR API and the conveyance of that technology. But there's a core piece of infrastructure that we still haven't nailed down in the US at least, which is the conveyance of cases from clinical care to public health agencies to support emergency response. That piece is only now, we're only on the cusp of it, and it should be there for all emergency events because that is part of the core that many of them indeed face.
John, can you say a word or two about this? Because there's been a fair amount of criticism, people like Farzad, Mostab Shari and others, criticism is the wrong word, about discussion about how some of the advances made sort of public health reporting, epidemiology around the time of, anthrax and even going back to 5 years ago with Ebola, have kind of been stopped or haven't got as far as they should have done with the CDC. And we're still, I remember there was a map, it's not so much FHIR related, but gets back to what Keith talked about bed management. There was a map of real-time access to ICU beds in Germany, and in the US, people were filling in spreadsheets or sending carrier pigeons or what have you. Can you give a sense of, reality where we are in that, mentioning with the CDC and other reporting, other national and state reporting?
Sure. So I have some slides that show a typical outbreak curve, and it goes to a peak, it subsides, there may be an outbreak, a flare-up afterward, but there's almost exactly the same curve that is about attention from clinical care in the rest of the country, and almost exactly the same curve, though trailing, about funding to support public health infrastructure. And all of these things follow and have a tail. And between emergency events, the attention that the clinical community has to public health requirements and needs is not high. And the attention that funders have to public health infrastructure and IT needs is not high either. So it's a difficult environment to develop sustained and support sustained infrastructure. So I think there's absolutely a validity to that. Public health has also sort of been taking advantage of what data it could get because it couldn't get the data it wanted. Think of it. Syndromic surveillance really started because chief complaints were in ADT systems. Electronic laboratory reporting started because lab results were in LIS systems and were easily accessible. But this whole new world of getting data from electronic health records has only really become available in recent times and offers a potential to the kind of rich data that are needed for outbreak management, demographic data on the patient so that contact tracing can be advanced, race and ethnicity data so that the outbreak can be characterized. These are the kinds of data you can get from electronic health records that you can't get from lab results, and you can't historically, certainly, and you can't get from some other sources.
So my history goes back probably as far as John's on some of this. John was talking about some of the early work in HITSB, that was the biosurveillance use case. There was a follow-up to that in biosurveillance that was dealing with flu response. And there was also the emergency responder use case. In HITSB, we called these respectively the anthrax use case, the bird flu use case, and the Katrina use case. And that is exactly the issue, which was the funding and the attention happened after the event. Graham said it earlier, we're always fighting the last war. And that's the challenge that public health has had. But we had systems. We had systems that came out of some of that work in reporting bed availability that were still going up to as late as 2017. The nurse that I spoke to, the informatics nurse that I spoke to at New York Presbyterian, told me they're actually running HaveBed down in the basement at New York Presbyterian. It's going to the New York State Department of Health, and nobody at the State Department of Health was doing anything apparently with that data, best we can tell.
Abby.
So yeah, like, I mean, we could put FHIR APIs and everything. 5 years from now, I'm not convinced that jurisdictional issues will be resolved. Is we can put the technology in, but we're also going to have county by county, state by state differences in how people want those things, like want that reporting to be done. I kind of worry that it's going to get politicized also. And you can put in the system in place, but if there's nobody on the other end of the line who wants to hear the data, you know, you're kind of back at square one. And we're seeing places that fundamentally, they don't even want to hear the reporting. They think that the reporting itself is a sign of, like, if we just don't do the testing, it will go away. So
Who would say that?
I would say that.
Nobody in the right mind.
No, well,
but it's true. It's
Yeah.
Those things exist, and so and there's going to be jurisdictional, there's going to be politics, and it gets back to the Bill Gates saying of if you automate the right things, you get efficiencies, but if you automate the wrong things, you increase the inefficiencies. And I think that there's also possibilities for like systemic, like because of the way the reporting is or is not set up, or which systems have access or which data. You know, we also run the risk of automating not just response to pandemic, but automating the incorrect response. And that could be disastrous in its own way too. So, yeah.
So
John,
maybe we can, I have a question here from one of the, how many, 90 participants that we have. This is a question, I'm not sure for whom, for a virologist probably. Are we seeing much variability in the genetics of the virus, either geographically or over time? And is there much data yet on how that flows through to manifestations, progression, spread? Is that Abby or John?
Abby or John, I would guess, unless Grahame or Keith have got sort of no.
Hey, I know what I've read. You know, I know what we have here in the U.S. is different than what originally showed up in Wuhan. I know that there is variation in viruses, but that's all I really know.
There always is variation. I've also read that the variation is not so intense that a vaccine, for example, couldn't still be operative. And so I think the jury's still out on the degree of variation, and I've heard reports both ways.
I've been reading like half dozen mutations per month, which as far as viruses go is fairly stable.
It's very small.
Yeah, it's not too high, not too low.
I guess the unknown question, which is whether people that have seropositivity for it are immune, and for how long. Is it does next year's flu come back? It's different. I remember I went to see Grahame. I went to HISA in Brisbane a few years back, and Grahame was there. And because it was 6 months before the US winter, I didn't have a flu shot. But the Australians already had their flu season, and I was like dying for 2 weeks afterwards. You don't, because it's a different flu shot than the one I had the year before. And I wasn't, and I think it's just too early to know about this. I'd like to turn us back to like a statement, not a statement. Well, one of the things that you were talking about just there, Abby, which is the issue of we have different counties, we have states, we have all this infrastructure that's set up because of the way the US is set up to deal with stuff. Occasionally, we get to a moment of real national crisis. We figure out a different way to do things. Usually around the military, usually around the NSA or 9/11. So now because going back to Graham's last war, you're still those of you who are flying, you're still taking your shoes off in an airport because there was one guy who tried to set his shoes on fire or bomb a plane, 15 years ago. I always joke that he got on at Heathrow Airport, and when you get on the plane at Heathrow Airport in London, you don't have to take your shoes off. But anyway, the point is we have a more or less a federal system of air traffic safety, because of those incidents around 9/11.
No. You actually use the right word, but it's the problem that we have because we in fact have a federal system for dealing with healthcare. That means federation.
Okay.
We have a federation of states. The United States curve, in terms of response to COVID-19, looks like Europe's or Asia's curve. It does not look like Korea's or Italy's or France's because it's 56 governing bodies deciding what our response looks like.
Okay, so let me ask the group the question. The politics of this. I was on I run a thing called THCB Gang, which is a podcast where we have fun on this, and I had John Loonsk on, who's had COVID. He's an MD MBA from New York City in this business, and he's African American. He was talking about the issue of COVID and the minorities and whatever, and he said, look, when we notice stuff, being the MBAs, it all comes back to money. Because we didn't have good public health, as Grahame was talking about earlier, we've spent, what, $3 trillion so far? I'm going to spend another $2 trillion to dig ourselves out of this hole. Someone's got to pay that off in America. Same things are happening in other countries. At some point, we have an election coming up. Does that get us the attention to think about doing something different regarding public health reporting, contact tracing, surveillance, all the stuff that we talked about, and integrating that into the healthcare system way? And if so, what does that look like?
Here's something different would be to support it with infrastructure, to support it with resources. The ROI on a dollar's worth of investment in public health is an order of magnitude better than in clinical care. But we still are not reporting. We are still not supporting it adequately.
Well, Medicare for all is COVID-19 is a great use case for Medicare for all. So that may be, a flu shot, a public reporting, and coverage for an ICU ventilator. In some ways, is a use case for kicking off Medicare for all. So that may in fact be how you pull those things together. But to the point about federal systems changing, I would, I do think we're going to see airports. I think we're going to see airport travel change as much pre and post pandemic as before and after 9/11.
That's a fair statement.
I mean,
what's interesting to me is when we talk about a nationalized health system, we're really talking about a system that is a public health system. And I think that what we've seen in parts of Europe where there is a nationalized health system and a nationalized response, that the public health response has been much more productive than what we have here. I love where I live. I live in the great socialist state of Massachusetts, and we've done okay. We have not done as well as we possibly could have, but I can see the impact that having that really very much focus on health by a government has a big difference in what's going on in terms of public health response.
I mean, you named the federated aspect of healthcare, public health. What the additional complexity that needs to be added here, though, is that in routine times, that implies specific flows of information. And when there's an emergency, those information flows change. And that's really difficult to deal with. So right now, the response is and information flowing, a lot of it's flowing to a federal level. During routine times, the cases flow to state and local levels. They need to do a lot of the contact tracing. They do the outbreak management. It's hard to scale that at a federal level in a country as big as the United States. So there are aspects of that system that are entirely appropriate and reasonable, but it's also disruptive when there's an emergency and things change.
Yeah. Great.
Can I interject a question here? Probably for Grahame by Mark Kramer. How does FHIR figure into observational trials? Is that one for you, Grahame?
Well, I mean, I suppose, although I'm not the only one with valid opinions here, we have some initial stuff, resources in FHIR around trial management. I'm not aware of those being used in anger at this time.
I am.
Oh, good. You can mention that in a sec. We also, I mean, we have lots of trials that are starting to collect data through FHIR and focusing on making that transition right now, and that's happening in multiple countries. And of course, we can describe those observations, and I've referred a number of projects to MITRE's work around the COVID data dictionary, which are published. So, I mean, it can be done, and it is being done in some small cases, but I'm not aware of anything really significantly scaled at this point in time.
So there have been numerous initiatives in the US that have been trying to scale up to 1 million patients, 1 million hearts, 1 million veterans, and most recently, the Precision Medicine Initiative. And a lot of the work that's happening in the Precision Medicine Initiative is starting to incorporate FHIR into it in terms of sending data from EHR systems off into what is eventually going to be an OMOP-based repository somewhere in the south, and I should be able to recall where this is because I'm working on a portion of this project doing standards that are related to FHIR in both HL7 and IHE for that particular initiative. So we're looking right now at how to get data out of mobile health devices, so out of your phone into FHIR and into that stream of precision medicine data that's going to Vanderbilt. So that it eventually can be used. And so those are fairly large initiatives, all of which have incorporated FHIR at one level or another, and more so.
Maybe there's someone in the audience who knows about these trials going on where FHIR plays a role. Then please unmute yourself. You can. No?
We'll give them a second. Okay, well, they can always bump in.
Yep.
Yeah, we do. Okay. No? All right. Well, we have 10 minutes to go. 10 minutes to go. I want to sort of generalize this up, but I think if I was to say as the lay observer here, what's the key point is that FHIR is necessary but insufficient at the moment because of all the other things that are going on. We also don't know what the next pandemic is going to be. We don't even know, frankly, what the future of this pandemic is going to be. And it intersects with so many other things happening internationally and socially that in society that it's going to be very tough for us to forecast what to do next. But on John's point, let's suspend disbelief for a minute and assume that we have the enlightened, rational future government of the US or the world, just go with me, that says, yeah, we just made a really serious mistake by not having the ability to track and trace and stop this thing when it got early and have to shut our economy down and have the consequences that we're now living through, whether it's 20% unemployment or 30% of small businesses going bankrupt or whatever it is. So perhaps I could ask Grahame the comment and then I want to dive in. What is the role of, if we need to get to everywhere, I think in the run up to this call, Abby was suggesting, we had to have Uber cabs or, and airports and, who knows, schools and whatever, plugged into a network so that we can do that understanding of tracking data from all those different types of environments, maybe shops, stores, grocery stores, prisons, God knows, people who aren't really plugged, nursing homes particularly, not really plugged into our current EHR networks at the moment. Grahame, is that a practical thing for the FHIR community to start working on? You say it takes 5 years to get something into production. What can this community do if they're asked if FHIR is going to be an integral part of the always on, always messaging framework that I made up earlier today?
Well, first of all, thanks for mentioning aged care homes. It's a significant concern to me that they aren't getting
Absolutely.
real focus in terms of surveillance. And we know that one significant risk factor is staff working across multiple homes. We need a coordinated system to track that. But that's not going to happen in this epidemic because it's not going to be quick enough. But more generally, like, we can't create the business conditions that would create the kind of healthcare system you're imagining. We don't have those levers. But what we can do is you can't create the business conditions without having the technical capability. We can create the technical capability, and so we need coordination with the business drivers, and we have various channels by which to drive that coordination. And then we have the other thing we can do is, once the business interest is there, it needs some seeding from government to, like, break the impasse. You can't do it because no one knows how to do it. No one knows how to do it because no one's interested in doing it. The government breaks that impasse. The business people go, yeah, we want to go there. And then but we need a community of practice. And that's where we help, that we can say, okay, you need to build a community of practice. You need a collaboration platform, and that's across a mix of social medias and face-to-face. You need a way to agree on what you're going to do, and then you need a place to practice what you're going to do. And that's where we fit in, is enabling that process once the drivers are established. For me, listening to you, we'd love to collaborate on that path, and we have lots of piecemeal things that are part of that path. But right now, we can't make the path. We can't create the drivers for the path. We can only respond to them.
Any other comments on that?
I'm a little, optimistic about, call it a free market view of the world. But I do think that there is an opportunity where we will see the hospitals and the existing infrastructure just kind of keep along with the old legacy systems. The mainframes, the V2 isn't going anywhere, but everything else will lift up with FHIR. And when companies are implementing things from scratch, the question is do you use this wonderful API that's ready-made, and you don't have to, it's going to be the path of least resistance for new products, new installations, any type of new facilities, whatever. So I have a feeling that other parts of the healthcare industry that may not have had large investments in health IT already are going to leapfrog, and they're going to land on pure telehealth FHIR-enabled infrastructure, because they don't have any pre-existing processes and installation to rip out. So I'm kind of optimistic about the other pieces leapfrogging and going in a way that we say, hey, we didn't even consider these as part of the healthcare infrastructure, but now we do. And
so in the last minute, I think the thing that I would want to say about this is that you really have to have the vision about what you want to do, about the problem that you're trying to solve, and devote the time and effort. We would not have gone to the moon here in the U.S. and if John Kennedy hadn't said, we're going to go to the moon, we're going to do this, it's going to happen. We would not have had FHIR if Grahame hadn't gone into seclusion for 6 months and said, I'm going to come up with the fresh look for HL7. You've got to have the vision to say, this is where we want to go. Matthew, what you're saying about, where we should be going in the US with our healthcare system, what people like ePatient Dave have been saying about what we need to accomplish. This is the kind of vision that needs to keep coming forward, that people who are involved in FHIR keep projecting around what can happen, what the possibilities are, and I think that's really been one of the biggest values in developing the FHIR community.
John, we've been given the hook, but you've got a 5-second soundbite before to lead us out.
I'm very optimistic about FHIR. I think it plays a critical role moving forward. I think some of what needs to be done is outside of FHIR in terms of identifying the fact that public health has requirements too, and we need to take those from this event, make sure that they'll meet the next event, and advance them in that infrastructure.
Yeah, I think we can conclude with saying FHIR is an integral part of the future of public health, and public health is healthcare. They should be still.
Yes.
So with that, I'm going to turn it back over to Ryan. Thank you very much. I want to thank Abby, Keith, John, and Grahame. I think Abby and Keith both went to everything. John and Grahame have both got talks tomorrow that you'll be able to see. I believe I'm right in saying that. Maybe John and Keith and Abby were talking again tomorrow, but great stuff. And thanks, Ryan, for the questions. And we're turning it back.
Thank you, Matthew.
Thank you.
Hey, Matthew.
Thanks, everyone. And I did get everything recorded there. I didn't want to turn up the music like at the Oscars and cut you off, but do want to respect that the next sessions start in a few minutes. So thank you, everyone. This recording will be available tomorrow under this agenda item. Bye.